Given what we have learned from COVID-19 pandemic, we should once again review our organization structure to better prepare ourselves for the next pandemic. The one big lesson this time is that we need to rely on the wide repertoire of responses. As I explained in the charts earlier, each pathogen has unique characteristics, needing different responses. In fact, COVID-19 shifted around the charts, requiring us to change playbooks along the way. Specifically, for a severe but less transmissible disease like SARS, we need an individual-centric approach, comprising testing, isolation, tracing, quarantining, that is precise, accurate, and as error-free as possible. But for less severe but highly transmissible pathogens like Delta or Omicron variant, it becomes almost impossible to contact, trace, and isolate, especially as the disease increases and spread exponentially. It is also of no use insisting on gold standard accuracy and precision. Instead, we need to manage the exponential growth of infected persons through population-wide interventions. Mask wearing, ART tests in the community, self-tests, quarantine those, self-quarantine for those who are exposed, home recovery for those with milder symptoms. The individual-centric clinical approach versus the population-based public health approach, they are actually not mutually exclusive. In fact, they complement one another, and we adopted both during different phases of COVID-19 pandemic. We should institutionalize both sets of capabilities for the long term and able to deploy both with flexibility and dexterity in future pandemics. To do so, we will set up a new Communicable Disease Agency, or CDA, under MOH. It will oversee disease preparedness, prevention and control, surveillance, risk assessment, and outbreak response. This new agency will consolidate the relevant public health functions that today reside in MOH, NCID, as well as the Health Promotion Board. The NPHL, the laboratory, is a critical national resource and will be transferred to the CDA. The CDA will maintain oversight of the clinical facilities in NCID. Many countries such as South Korea, UK, and US, they have similar setups. They too, after COVID-19 crisis, is also reviewing their organizational setup. In addition, MOH will separately retain a permanent crisis strategy and operations group in the ministry. We call it CSOG or CSOC. CSOC was established during the pandemic and grew steadily as the pandemic progressed. It is the machinery behind all the pandemic-related operations that we are familiar with. Contact tracing, home quarantine, conveyancing to isolation facilities, testing, vaccinations, home recovery. All this coordinated and implemented by CSOC in MOH. CSOC was staffed by officers from various ministries, contract staff, and also staff from industries affected by COVID-19. For example, we had quite a number of SIA pilots as well as cabin crew working in CSOC. Most of these staff have returned to their industries. As Ms. Poli-san said, as it rebounded from 2% to 80%, we lost all of them. But yet, we're sad to see them go, but we are happy that they are gone too, because they are going back to their industries. So the operations have scaled down greatly. Nevertheless, we will keep a permanent CSOC force to maintain surge readiness for a mid-sized outbreak, as well as other health emergencies. And this includes preparing healthcare institutions to be crisis ready. In peacetime, when there's no emergency, they help us operationalize Healthier SG. As the skill sets turn out to be fairly similar, because it's not surprising because they are both public health focused. In addition, we will set up a healthcare reserve force made up of ex-healthcare workers and volunteers. We will train and equip them to reinforce our operations. during larger surges, and they will complement the existing pool of SG Healthcare Corps volunteers. Finally, we will change the title of the DMS. Instead of Director of Medical Services, he will be called Director General of Health, which more accurately describes his role as the main overseer of both clinical and public health of Singaporeans. This will take place after the changes to the Healthcare Services Act come into effect later this year. This House has already approved the changes. With these changes, MOH will be organized to place greater emphasis on both clinical services and public health. They require different instincts, considerations, capabilities, and skill sets. Both are important and critical and will be institutionalized and built up within MOH.